So I've presented versions of this lecture at lots of different things. I think ReGum is the simplest way to save more teeth in practice. But I want to talk to you about some basics first because we won't understand its use properly or we'll have some failures if we don't treat it right. Um, I am paid to be here, but I use it and love it. So that's just a perk. But I should tell you that that is a conflict of interest. As you can see, I'm trying to talk to students about making flaps and doing things. We like to have fun in practice. So, enough about me. Let's talk about why we use this. Why is this important? Oral issues are likely to be seen in 3 out of every 4 pets. If you look at the statistics at the bottom of center here, for Strati studies from the 90s, they still hold true to today. And 72% of dogs and 86% of cats have essential or additional findings beyond exams only shown radiographically. And so I kind of compare teeth like icebergs. When we look at teeth, we're only seeing a third of each tooth. 2/3 is underneath the gum line. And dental issues are the most common. And because most of the issues are happening underneath the gum line, it's the most underdiagnosed disease in dogs and cats. And there is an association repeatedly relating inflammatory processes of the mouth to other diseases within the body. So basically, when you're keeping the mouth healthy, you're helping to keep the rest of the body healthier. A study in 2019 on 2 million dogs showed that those that had annual anesthetic dental procedures lived 20% longer than those that had no or irregular dental procedures. While it's not a cause and effect that's direct, it does not appear that anesthesia is cumulative. And I have whole talks on anesthesia and pain management and local blocks. It is not something we should just do without, caution or risk. It's something but it can be done well. And age is not a disease. So we don't not do procedures because a patient is old. If anything, the older ones need it, and we need to intervene sooner. In fact, pets are 5 times more likely to have periodontal disease than people. We measure periodontal disease by bone loss around teeth, and I'll have a specific slide explaining those levels. A 2018 study by my friend Kathy Queck, she used OraStrip, and OraStrip DX is a little test that sometimes we talk to our clients and they don't believe there's anything there. And they don't even want to do anesthesia to be able to do x-rays. And so OraStrip is something that can be a tool to determine we might need to do a dental procedure and thus find the need for ReGum Vet. But OraStrip is a thiol test. You just wipe it, just like almost like a urine dipstick, but it's one little tiny pad. And you just wipe it on the gum line and you wait 10 seconds and it gets a color change. And the presence and increasing yellow color correlates with bone loss. And they've showed that basically 85% of dogs age 3+ already have bone loss, and 53% of dogs already have bone loss between ages 1 and 2. So this is happening, and it's happening earlier. I'll refresh those numbers in a moment on the next slide. But there is definitely more prevalence with advancing age. And in a study in 2014, there's 53 20-pound dogs. They were only aged 1 to 7. All of these patients had their teeth cleaned. Anything that was treated, they were treated. And then they came back because none of these owners wanted to do home care, and they came back and checked them every 6 weeks. Not with OraStrip, but with radiographs. And as soon as they found bone loss, they were out of the study. All but one dog was out of the study in 66 weeks. And for every year older they were, it happened 5.5 weeks sooner. Now, these are smaller dogs, they're more likely, but it's happening hidden, and it's happening faster than you think. It's kind of funny how 66 weeks is really close to a year. So yearly dental procedures under anesthesia should be our standard. And then more if necessary. So this is the data on the OraStrip DX, where it showed that 53 and 87% of pets. And before they were looking at the numbers like we see on this yellow strip, now they just call it plus degree of yellow. So essentially it gets a little bit yellow. You have a 53% of bone loss probability. Once you hit the middle of that, you have a 92 to 100% chance of bone loss. And what we're talking about is plaque biofilm, which might be a different slide. But I'll get to that. So what is this thing, periodontal disease stage? Sometimes we're flipping the lip and we're looking at the patient and we say it's stage something. We really shouldn't call it stage something because none of us have radiographic, like x-ray vision. So we don't know what's going on. And when we can look at these pictures and we're guessing these are the right stages, but it's a pure guess. There are patients that have really thick tartar, but it actually hasn't caused significant bone loss because the plaque biofilm hasn't changed and caused that. There are plenty of patients that have what looks like stage 1 in this picture and have tons of bone loss. And so we can only refer to stage when we know the amount of attachment loss, which is going to be based on radiographs. So this patient of this tooth on this radiograph is a stage 1. There is no evidence of bone loss. The second one is a stage 2. There is 1 to 24% bone loss on the mesial root of that tooth. On the distal root of this third picture, there is almost greater than 50%, but there's definitely between 25 and 50% bone loss on the distal root. And then stage 4 are not usually this bad, but this one's so bad it involves the apex. And I also have a saying, I like to save teeth, and we can save all teeth, but sometimes like this number 4, once the apex is involved, only in a jar. So when we're evaluating teeth, we want to examine them. We want to probe circumferentially. We want to take radiographs, and we want to make sure we're tactile and not stabbing anything in there. The main component of this is that I want you to realize that part of your oral exam, I rely on my team members for. I use them to help me. I'm going to probe as well, but they are double checking me and circumferentially evaluating as they're cleaning those teeth. They're taking the intraoral radiographs. And so my team members really get to participate in these patients. And if it's a dog, that's 42 tooth patients you're treating. If it's a cat, that's 30. Unless they're like most cats that like to lose teeth and it's less and less. But essentially, we are talking about treating these areas, and your team members can become much involved with what you're doing. But when we probe, we might probe and find that, get this up here, 1, 2, 3, 4, 5, 6, 7. So we have a 7 millimeter pocket, but we have to realize a 7 millimeter pocket doesn't necessarily agree with the amount of attachment loss, because there's also a 3 millimeter root exposure. So this is a 10 millimeter attachment loss. Now that also means that if the patient has excessive gingiva and it went like this, and you probed like this, and you got 15, it's still only, because this would be 5 and this would be 10, it may only have 10 millimeters of attachment loss. So periodontal pocket depth does not directly correlate with attachment loss, but it's something to understand. So in that example where we talked about gingival enlargement, if it only probes to this level, then we're talking about gingival enlargement. There may be a periodontal pocket, but it's a pseudopocket. It is not actually bone loss around a tooth. And probing might indicate something, but I really don't know the degree of bone loss without a radiograph. So we would probe to determine what's going on and what we need to do. This is a case in which our probing depth is 1 to 2 millimeters. There's a touch of blood, so it definitely has some active disease, but it is not significant pocket depth, but there is some attachment loss. So we just need to understand the differences. That will help us make some decisions on how to go forward with treating these. When we're talking about periodontal therapies, our goal is to minimize attachment loss. We want to minimize our pocket depth, because that is actually, like on that last patient that had some root exposure, even though there's only a 1 to 2 millimeters pocket and it's slightly has a little bit of bleeding, the pocket depth is not significant. So your chance of healing that area is excellent. Our goal is to maintain attached gingiva and remove biofilm. So what is this thing, biofilm? That is that fuzzy, that's plaque, that's that fuzzy feeling when you wake up in the morning. So that forms on any wet surface. Now, biofilm is 10,000 times or 1,000 times more resistant to antibiotics. I mentioned that because some people think they can throw antibiotics at a bad trash mouth and fix it, and it's not going to work. The veterinary team, that is the people that we're working with. That was going to treat things where it's happening in the gingival sulcus. No one else is getting into the sulcus while a patient is awake. It's the veterinary team that's going to be doing that. And you can technically sterilize the gingival sulcus, that space between the gum and the tooth, and it'll reform within 2 minutes. It actually begins within nanoseconds, but you have a normal biofilm within 2 minutes. But your predominant types change over time, and then you get an increase of thiol production, which relates to bone loss. So you can have a normal biofilm. You will have a normal biofilm. I currently have a normal biofilm. I don't necessarily have plaque on my tooth surfaces, but I have plaque in my um, uh, gingival sulcus. That is something normal. And it's the normal colonization that happens. But our team needs to keep this in the normal. It's its own community, basically. That's a whole long lecture. Anyway, so this is a hidden disease. There is an association that relates the inflammatory process amount to other diseases in the body. And we, the veterinary team, the only one can treat that. So we need to treat stuff in this sulcus space. And it talks about that at the American Animal Hospital Dental Guidelines. There's some information on that if you wanted to find a bunch of guidelines at bit.ly/ahadent. So when we talked about bone loss, stage 1, that's no bone loss, no attachment loss. This is gingivitis. Sometimes we have an increase in sulcus depth, but it's still in the 1 to 3 millimeter, but it's gingivitis. And tooth size versus millimeters is different. And so if I have a 10-pound Chihuahua and I have a 3 millimeter pocket depth at an incisor, do you think I have bone loss? I know I can't have the audience respond because we're on a webinar. I'm going to say yes, because the probable root length is like 7 millimeters. And so we're probably already at a stage 3 or 4 if it has a 3 millimeter pocket at an incisor, and it's probably already mobile. And so we have to take this with a grain of salt. I also have seen huge Newfoundlands and things like that in the canine. I get a sulcus depth probing of like 8, and yet there's no bleeding on probing. It is still totally fine. It's fine. So this is an average typical dog sulcus depth. Cat would be 0.5 millimeters. What happens when you see this is and it's normal, you're going to clean it. And after you're cleaning, the edema subsides and the sulcus will return to normal depth. Unless there is some bone loss, then it's permanent bone loss. And so early periodontitis is up to 25% attachment loss. That includes 1% as well. And it would just be cleaning. Now, we have to watch the junctional epithelium at the base of the sulcus. We need to talk about the periodontal ligament and the gingiva. I want you to note the differences here. When I say gingiva, I'm referring to the gingival collar. See, I wrote the G on the gingiva here. And then the stuff below is the M, mucosa. And then this thing right here is the mucogingival line or mucogingival junction. The problem is if we get some gingival recession, you may get enough gingival recession that it recedes to the MGJ. And if it recedes to the MGJ, you're not getting gingiva back. And then you no longer have a collar of gingiva around that tooth. So it doesn't matter if the bone loss goes like this and always stays small, because if there is no collar of gingiva, it will just cause a whole bunch of recession of the mucosa, and you may as well just say goodbye to the tooth there. The important part about that is when you're talking about placing ReGum and you're talking about any kind of oral surgery, if you have a tooth to preserve, it is important to have a collar of gingiva. So that's the important things to remember with this. But the treatment for these things, most of these are treatable. We want to, might have a little bit of root exposure. Root exposure without a pocket, without an abnormal pocket depth is fine. We want to clean those areas. And most of the time we're talking about closed root planing. We'll talk about what closed root planing, open root planing is in a minute, but that is cleaning that area into the sulcus at the appropriate depth. And most people see pockets like that. In general practice, they're known to do ineffective closed root planing, and then they place a periosutic. In the US, we talk about doxyrobe. Clindoral is also available, and recently became available as PerioVive. Essentially, these are things you just squirt in the pocket like a liquid. It's supposed to be a barrier membrane. The problem is you're usually putting this goo on top of disease because you didn't clean it out well enough. And the thing is, I would encourage you to be aware of this study. A Martell study, I forgot what year, they compared just closed root planing and doxyrobe. So they would clean the teeth with closed root planing, excellent closed root planing, make sure it's all clear. And clean the sulcus out of the pocket depths 4 to 6 millimeters. And then half of them, and they was split mouth study, half of them they placed doxyrobe in there after cleaning, and half of them, and doxyrobe is a barrier membrane. It's Atrazorb, I think, in Europe, plus doxycycline in the US. Atrazorb without doxycycline. So half of them had real closed-root planing plus doxyrobe, the other half just had closed-root planing. And they came back and they found 3 months later that the ones that had no doxyrobe were equal or better than ones with doxyrobe. So a periosutic isn't necessary. The best medicine for these patients that have stage 2 is closed-root planing. In other words, cleaning the teeth properly. And I'm stressing this because cleaning the teeth properly is going to be helpful because that will also matter your success of ReGum. If you don't clean it properly and just put ReGum on top of dirty stuff, not going to work so well. So we have to understand that. And this is something your techs can do. This is cleaning of the teeth. It might be below the gum line, but it is cleaning of the teeth. You might need the veterinarian to have the license to open the area because we need to talk about the differences here, but the technicians and the team members can still clean those areas as long as they know how to use the instruments. So there's studies that show even if you reach, once you reach 5.4 is the millimeter, I'm just going to say 5. Once you get to 5 millimeters, you think you're going to clean it out well, but you're not. Once you get 5 and up, you need to open it up to clean it well. And I'll show some examples of that well. So how do we clean these? If you watch a video, it's going to show a version of this at ReGum Vet. I will add more things there, but tooth.vet/ReGum Vet is a video on how to use these instruments, which I'm going to review with you now. Usually I'm talking to a big audience and I say, oh, do you know what a curette is? And half the people raise their hand. The last time I did that, half raised their hand, and then we got into lab, an actual wet lab, and those people that raised their hand know only like 10% of those knew what it was. So it's okay if you don't know, is what I'm trying to say. We didn't learn enough in school. We need to learn that. And there's a difference. This is a curette and this is a scaler. Scaler has a sharp pointed tip. It's above the gum line. A curette has a rounded tip, and there's multiple types of those. And they actually make ultrasonic curettes. I think these are made in France. Anyway, they're an H3 tip. It's an ultrasonic curette, and that's my favorite tool. So we have to look at the differences. So scaler is super gingival, and it's got a sharp pointed toe. So it's getting the stuff off above or in little grooves above. Otherwise, a lot of people think about universal curettes. Universal curettes, just like you see, there's a red line here and here. These are 2 working edges. And so in cross section, if you looked at it like this, you would see 1 working edge here and 1 working edge here. In other words, you take the tool and you place it into the pocket, and then you have to turn it 10 to 20 degrees to engage the face against the root, and then pull up to clean that root surface. You can do that with either side. I have a hard time when, especially in a pocket, when I can't see it well and there's blood in there, figuring out what 10 to 20 degrees is. And so I am not a fan of universal curettes because I'm not sure that I've got the right angle to engage that face well. And so I'm a fan of Gracie curettes because it already has that angle to it. And as long as this terminal shank or shaft is parallel to the root surface, you will get what you want. You place that in there all the way down. And as long as the tooth root and the terminal shank here are parallel, then you will always have the right angle. And there's only 1 working edge because it's angled to that side. And the opposite side, when you flip the tool over to the other side, is the opposite side of the tooth shape against it. Anyway. And they do make universal Gracies. La Marta, Europe area makes them. IM3 does have one out of Europe. They're bringing to the US. In other words, they are available, which in other words, as you see, has 2 working edges, both at the same angle already. They're less common, but they do exist. Same thing, go down, pull up. Okay, so then we talk about stage 3. This is up to 50% attachment loss. This is where we're going to have to decide which tooth is it. There, in dogs and cats, and we're really only doing this for dogs, and I'll explain why soon. But there's only 8 important teeth. the canines, they're their fingers, the fangs, and then the carnasals, these big two-ring teeth, which are the maxillary fourth premolars and the mandibular first molars. Those are the only 8 important teeth. They are the strategic teeth, they're the structural teeth. It's not exactly true, but it's really darn close. If a dog had those teeth and those 8 teeth and no others, they basically have the same structure and function as a dog that has all 42. So those are the teeth you want to treat, and those are usually the teeth that have the problems. You have to think about the patient. If this patient has a raging heart murmur and needs a follow-up care, maybe this isn't the best, or it's a horrible diabetic. Maybe this isn't the best one to treat. Maybe it's better to remove the tooth in those cases. Now, most of them you will not have those situations, and these are important strategic structural teeth we need to keep. You also have to consider your owner. Will your owner comply with follow-up? Usually not that bad for follow-up, but they need to do that. And you can't decide what it really is without radiographs. So we'll come back to stage 3, but let's talk about stage 4. Oops. Okay. Stage 4, greater than 50% attachment loss. If they have mobility, say goodbye. If there's so much severe change that it's really, really deep, and you don't have a sufficient gingiva, you need to get rid of it. Most of them you have to say goodbye because they're like this picture of garbage mouth. But there are plenty of situations in which we can treat these patients, but your choices are going to vary between your difference of horizontal bone loss and vertical bone loss. So let's think about those situations. Is this horizontal bone loss or vertical bone loss? I'm sure you guys already figured that out. This teeth are being basically kept in place by a periodontal splint, a calculus splint. Um, these teeth should say goodbye. It doesn't matter what you use. These are too far gone. Say goodbye. But make sure for your own, protection that you've taken full mouth radiographs of all the teeth before you call the owner, because this particular patient took the radiographs and was already broken. Otherwise, they're going to accuse you when you take out the tooth that you broke the jaw and it was already broken before anyone did anything. So that's important. This is a case where the dog had a cyst. And there wasn't really a pocket of this area, but the cyst, because this tooth was dead, had already involved the apex of this tooth and also started involving the apex of this adjacent tooth. So even though there may be something to treat here, these need to go bye-bye because you don't have an apex that has a vital blood supply. Say goodbye to these teeth. Those are the exceptions, but I want you to be realized that those exist. So let's talk about a case. We talked about the differences in bone level. Basically none, 1 to 24, 24 to 50, 50 to 100%. What are periodontal? Well, first of all, horizontal or vertical bone loss. We talked about that already. This one would be a through and through furcation with horizontal bone loss. I didn't talk about furcations, I forgot. So furcation is the space between the tooth root. And once you have a furcation exposure, that is definite an issue, and ReGum has our only potential to work in this area. It's a little bit challenging with furcations, but we'll talk about that. What is the periodontal disease stage based on the root alone? The root alone is 2. It's 1 to 24%. But the trick there is once you have furcation exposure, it's +1 to whatever this is. And FE1 is less than halfway under the crown. FE2 is greater than halfway under the crown, and FE3 is through and through. And so since it's +1, this is a periodontal disease stage 4. And I just said periodontal disease stage 4 should say goodbye. Historically, before ReGum was available, you can see in this top picture that you push the gum line down and it acts like a one-way valve. You can just shove the probe right through this. And your treatment for these typically would be extraction. The or not is maybe because of ReGum. Historically, you were reducing the margin and exposing the roots, and you just had to clean these teeth every 3 months. And most owners won't comply with that, and you may as well just say goodbye now early. This case, you can see how it kind of acts like a one-way valve. This was my resident mate's case, and she cleaned it out. The owner didn't want to do anything then. You can just do what the owner says, knowing that you have to come back, and whether or not she did was a whole other thing. I didn't follow up. But she talked to the owner and said, I found carrots underneath there. And the owner said, I haven't fed carrots for 6 months. So things are getting hidden and stuck there, and they can definitely be issues. If you have that there, we want to treat it. We need to allow it to be all the way open, or because there is sufficient gingiva, it looks fine, even though there's already bone loss through and through. This, because there's sufficient gingiva to cover it, this would be a perfect case that I would want to put ReGum, as long as the other side also had this appropriate gingiva, in that site, because we have ReGum working, and that there's the only potential to work to get that out to heal that area. And so this is a case where it's an FE2, not an FE3. And you can see the difference in bone height. It does come all the way up, meaning it did go underneath the crown, but not through and through. And then 3 months later, look at the bone that came back with ReGum. Statistically significant bone change with ReGum. And so we now have potentials for furcations that can make a difference by using ReGum that we really didn't have before. So here's a different example. Horizontal or vertical bone loss. Vertical bone loss. Periodontal disease stage. Percentage of the tooth. Looks like more than 50 to me. PD4. But both of these patients are PD4, and this one clearly is worse. But I actually can treat this one with guided tissue regeneration, which really what ReGum does, allows you to do that in practice. Easier, simpler. But in this area, the mandibular first molar and then the mandibular fourth premolar, they're usually overlapping. And your first step is cleaning that area properly. So you have to be able to get down in there and clean that spot out. Now, this was a greater than 5 millimeter pocket. They're overlapping. We take our radiograph at often. I don't know if you can see me. It looks like this, and you can see that they are apart. But when you're straight on, they're overlapping just a little bit. And so you cannot get a tool down in that area to clean that area well. So we have basically euthanasia. We electively extracted 408 to save 409. And we're cleaning that area out, and you can see how we've opened that area up, and we can get down in there, and we have bony walls to help hold everything in. And then we can place ReGum and a barrier, which ReGum is a barrier as well. And then 6 months later, we can never return it to 100% because bone will only go back to the lowest wall. But we've already permanently have some bone loss, but we don't have a pocket and we have healthy area. So we can bring bone back to the site. We currently have some bone loss, but that's healthy. And this, even if it's PD2 permanently, because it already has some permanent bone loss, this can be inactive periodontal disease and permanently PD2 and be a healthy, perfectly normal tooth in your mouth. Not your mouth, your patient's mouth. So what is this GTR thing? This is formation of new bone through use of a barrier or a membrane. In this case, a scaffold with ReGum. Traditionally, it's a bone graft with a membrane. If you don't use a barrier or a membrane, it doesn't work. They had studies where they just use a barrier or membrane can get a benefit, but it's been shown that epithelial cells migrate 10 times faster than any other cells, and those soft tissue cells go down into that area if you don't have something to keep that out. And so that's why you have to have that. Historically, in the US, it's a doxyrobe made as a membrane. They can make fascial membranes with Morova and veterinary transplant services, but that's why I really like ReGum, because it acts as a barrier and a membrane. And so it prevents soft tissue from entering the site. And the ideal ones, something there should support osseous regrowth. And so we've mentioned those different things. Oh, and PRN is the distributor in the US, but they distribute it for BioChange. I forgot to change that, so you knew that. So what do we talk about when we talk about graft materials? I'm sure you've heard of bone grafts and things like that before. Some of them are osteoconductive, inductive, and osteogenic, those kinds of things. Essentially, osteoconductive things are scaffolds. Osteoinductive have biologic mediators. And osteogenic could be blood itself, but it less than 1% of circulating cells are progenitor cells. So we talk about osteopromotive situations. So these things promote the formation of new bone. They act as a scaffold. ReGum does that. They can be osteoconductive. The cellular surface encourages cellular attachment and migration. That is something that ReGum does. It's ReGum Vet. I'm sorry, I'm abbreviating. And osteoinductive. Technically, alone, ReGum Vet is not an osteoinductive thing. But the thing is, how I like to use it is when it's placed, it is absorbing it's going to absorb fluid if you soak it, or it's going to absorb the patient's own blood, which means that you are getting the blood into that area. And so you are bringing growth factors in the form of the patient's own blood to make it osteoinductive, as well as maybe to some level blood osteogenic as well in the same manner. So it has that potential as well. So this, the cool thing about ReGum is it osteoconductive. It can have osteogenic properties in vivo with blood. If you use a blood clot own, it is osteogenic, but what happens is as that clot is healing, that clot is getting smaller and smaller and it's condensing as it heals, and you'll get, it's been shown, is it 6 to 15%? I can't remember. There's a study that Chris had shown, Chris Snyder. He's a veterinary dentist in Wisconsin, University of Wisconsin. He had statistics on what, just when you take out teeth and then you close them up, what the average alveolar ridge height loss is when you just close those up. In other words, yes, there's always some. The patient should be fine, but some patients it really matters, especially when you have thin bone of the area. So if we can have something to support that and minimize your height loss, that can help you. So this is part of a handout, which I need to send to Hillet if I haven't already, that she can send out to people. It talks about ReGum Vet and kind of how it works a little bit. And it's cell foam and how it's used. We'll talk about the other sides of that handout in a minute. So we talked briefly about stage 3, then we gave some examples. We talked about stage 4. And these are situations we want to be able to treat. Too much caffeine this morning, I guess. Treat our stage 3 cases, and some stage 4 cases are appropriate for treating. So we need to evaluate the extent and type of attachment loss to decide on how we're going to treat it or if it can be treated. If there is so much root exposure, if we lost gingiva, like there's not enough gingiva there, and there's so much bone loss, we have to say goodbye. This tooth has to go bye-bye. This one has to go bye-bye. If, depending what bone level is here and what bone level is here, depending on the quality of this gum tissue, there's a potential of saving this one, but probably not ideal. We need to have sufficient gingiva to close or find a way that we can get sufficient gingiva to close. And we need to know what it looks like radiographically to make that decision. Flaps when you're opening these sites will allow greater access. If there is greater than 5 or plus millimeters of probing depth, we have to open that area to clean it well. And I've already talked about if it's a furcation, it's a 1 stage higher. Those teeth are at greater risk. They are more challenging for home care, but we have potentials to treat those sites. So this is a situation with ReGum Vet where we had furcation at the mesial aspects of the upper 4th premolar. So like we all have built-in positioners for x-rays at looking at upper 4th premolars. This is my right hand and it matches up to the right upper 4th premolar. These 2 mesial roots that V on cross section, right there, the furcation between them was exposed in this patient. And so this furcation was exposed here. And she did some great open root planing of the site and made sure the tissues closed around it with a nice gingival collar after placing ReGum. And 6 months later, it's looking great. And she saved this tooth, which is an upper 4th premolar, one of those 8 important teeth, on her own dog. So a veterinary dentist, but she had the product back then early on. So this is a situation where I really don't have sufficient gingiva, and this is one of my earlier cases, but I didn't come back all the way because there wasn't sufficient gingiva. But this is what it looked like radiographically. And placing it, it's hard so that I could push against it and really pack it in there. But it is on the, come back to that in a second. So I lifted the area, cleaned that out because it was, even though it looks huge, once the gingiva was lifted, we were able to have less than 5 millimeters here and clean these roots and make sure there's any granulation tissue in this area was removed. And then I dipped the product in saline and then pressed it in place. Now I waited because I didn't soak it and I wanted the blood to fill the area. And as I was placing it, is splitting and going up into these sites. And so that's what this little video is going to show. And I'll show you another example as soon.
left it hard so that I could push against it and really pack it in there. But it is on the crown. I need it at the root.
Not edited well. Sorry. I'm waiting for blood to fill the space. So this is not normally this hard. I intentionally did this so that blood would fill it. So I did not soak it enough intentionally. But now you can see how it's moving and starting to split and going up in those
Blood is
sites.
softening it and allowing me to fit that in there.
And if you have excessive, you can just kind of pick it out like that, which looks great.
Just have to make sure.
Has to be at the roots, not the crown.
Closes.
And it's closed. So this is what it looked like closed. What I really wasn't realizing, I was being wishful thinking, is that this gum line should be here, and it's just not doing well. So when I came back, it was filled in great here, but not here. And so we actually did as a smile effect where you can bring it down and increase the gingival collar. And I've lost that one to follow up. I have called the owner, but I'm not sure. They're always busy. So anyway. So I'll show you some others that have been successful, but we're using these for bone loss. And the best case is when you have infrabony pockets, which are bony walls to hold everything in. You have to remember that the soft tissues grow more quickly, so we have to get those areas. And cleaning it out first makes a big difference. Otherwise, you're putting a product in on dirty area, which means it's not going to work. So another common site that have an issue is a maxillary canine, the palatal aspect. So this is looking at those infrabony pockets of the maxillary canines. Think dachshunds, except usually by the time you find a dachshund, it's already into the nose, and ReGum has a product that might work well for those. But this is an historically old case before ReGum was available. You see the pocket, I pulled back the flap. I placed the graft in there, but if there's no barrier, it's not going to work. This is the old barrier. They're really hard to deal with. These products are expensive. It did work and heal this area, but here's another case where it looks like when you pull it open, that's the granulation tissue. You want to get that all out. See this blue thing? This is my suction. You need to use suction when you're working in these areas to be able to see what you're doing. And then I cleaned out all the granulation tissue, and then I'm using my hand instruments and cleaning against this infrabony wall as well as the root of the tooth. And this is what it looked like. And I would recommend that everyone learn that they should take a picture once they think that it's perfectly clean with their phone and zoom in, because I don't know if you can see that right here and right here. I'll take those off. Do you see that? Did I clean it well enough? No, I did not. I know what I'm doing, and I still did not clean it well enough. Blood is filling that hole. This is a tiny patient usually. It's filling it up. So use your phone, take a picture, look at it, zoom in, and this is why it looks clean, so perfectly clean, because I sucked it out and took a picture really quick, and so I could see it. And then I went back and I cleaned it out, took that dirtiness out. So basically that tartar is now removed, and the walls are clean. And then again, this was pre ReGum. I placed a graft in there, but the soft tissues would grow in faster. And so this is making my own doxyrobe membrane. And there's that membrane, and we closed it up, it healed well. So this is one that also has worked well. This is with ReGum. So opening it up, you can see there's some granulation tissue here. I did not trim the flap very well yet. We have blood in there. We're cleaning and cleaning. And so I'm starting to clean it, but it's still not clean yet, but my wall is clean. So I got to keep working and make sure all the granulation tissue is out, but it's really close. And then once it's clean, prepare to close, meaning you want your edges freshened, because as soon as I place ReGum in there, it's so easy for me to dislodge it and then get mad at myself because I had it just nice where the blood absorbed it and it's sitting there nicely, and I'll dislodge it. And so this, you can see how its area has been prepped, it's ready to close, and then ReGum was placed, and right now ReGum is starting to absorb the blood. And this is a square that filled this area, and there's actually blood that goes all the way to the wall. The blood's starting to fill over that area. And this is a cone filling this little area right there, how it's just going right here. So we're waiting for blood to fill that area, and then it filled it and acted as a basically a graft, a scaffold, and a membrane. And then we closed over it, and we came back, and that site, we came back at 4 months, completely healed. So the previous pocket depth of 6 millimeters was reduced to normal sulcus depth of 1 millimeter. So how do we use ReGum Vet? You want to prepare the site, make sure you do open root planing or close, whichever is appropriate. You want to release and trim your flaps so they're ready to close. Take your product, your square, your cone. I just dip it in saline so it softens enough that I can trim it if I need to trim it. And then I want to press it into the site so blood is absorbing and filling up that area and acting to make it more of an osteogenic type of capability. And then we close it. And that's why I'm getting it prepared to close, because if I had done this after, I dislodge it every time, and it works, but it's because it expands with the blood, it doesn't sit in there as nicely. So if I am ready to close right after I've placed it in, it works every time. So that's just my recommendation for using the product. And these are the things we've already reviewed. Thorough cleaning, tension-free flap. That's a standard with any surgery. Make sure there's a tight gingival collar. I had one that I thought would work well, and I did not have a tight gingival collar. We'll talk about that at the very end as well. And that's good for pockets that are 4 millimeters or greater. It's excellent for cases of vertical bone loss. And horizontal bone loss, it really won't work. But if it is like an edentulous area and you want to work on the side, it can bring the gum line around and help that. And you need to have sufficient gingiva, not mucosa, to cover that site. So this is an actual case.
So there is bone loss around the distal root, and we have a 6 to 7 millimeter pocket. But the concerning one is we have furcation exposure 2 at the mesial aspect of 208. And so we can get in there and we can get in here. And that depth is missing bone between those two roots. And there's no way we can get a tight gingival collar here without taking out this tooth, and there's already bone loss at this tooth. So we're going to sacrifice this one to be able to do open root planing and treat the furcation. This is a Gracie curette. We can see that has one face that is sloped, not flat, when we consider in relationship to the terminal shank. And so the working edge is right here, just one working edge, and the opposite side would have this side as the working edge. But I want to use a modified pen grasp, which is, like grasp like a pen or pencil, and then we're just going to modify it. And we want to get this surface in contact with the tooth root. And so this area has been opened. I'm going to reach down in there to the base of that pocket, and I am going to make sure that plaque and tartar is removed from that site and get out any granulation tissue as well. I'm going to do that on all of the roots. And go on the inside here too, because we have furcation exposure. Now let's rinse it and see how it looks.
Take a picture.
Release the tissues off of the palate, off of the bone. And so I'm gonna, normally I'd hold this instrument differently. I'm holding it so you can still see what I'm doing. I'm gonna go against the palatal bone. I'm just gonna lift it just a few millimeters so that I can expose that area. Make sure we have good visualization. Now let's suction in that area. Okay, so I have released it off of the palate, and then right in here is where we have our bone loss. And then we want to use our instruments, double check that that area is clean.
releasing your tissue makes a difference, so you can get access to the area.
This
and
is
also
where you
not
take a
too close.
photo with your camera. And you use suction when you do it. Go ahead and let's rinse this. We want to see it's right in there. And now suction or air or something. And so I see no diseased tissue in there.
A lot of times I can see better than the videographer, so sorry about that, but not bad.
It looks like it's clean. So the first step is cleaning. We've done that. And the next step is prepare to close, because we place our everything in here. This is going to dislodge it all. So I'm going to get these tissues healthy and ready to close. First, I want to make sure we have, healthy tissues as well. This is gingiva, this is mucosa. We have a nice gingival collar around this too. And I can't just close it, leave a gap. I need this to come all the way around there. So I want to make sure that any mucosa is released. So I'm just going to kind of fenestrate the periosteum underneath the mucosa a little bit. And then I want to make sure this edge is fresh and healthy. So I'm going to trim that. I don't know if you saw that little bit of cruddy tissue I removed. I'm going to suction right here again. You see there's cruddy tissue right there. Not very much, but it's going to be on this edentulous area. And then this has cruddy tissue on the inside aspect.
So technical. My words.
So now you can see how healthy that tissue looks, nice fresh cut edges on there. So now I'm going to prepare, we've trimmed it and ready to close, tension free. Because when I go and set this down, it pretty much wants to stay in that position. So it is tension free flap, but I might dislodge it as I'm placing those stitches. So I'm going to start by pre-placing my suture. I am pre-placing with my mono end MT taper needle 5/0. I'm pre-placing this suture in preparation to have a nice tight gingival collar. That is a key component. Now we are going to place ReGum in the site. Here's our graft material. This is going to be bigger than my site, but this piece fits nicely into that furcation. So I am going to open it up, and I want to dip it in saline. My cheat method for dip it in saline is place a little bit of saline in your pouch. So we're going to take our graft material, we're going to moisten it. See how it's been moistened in the saline? So that should be enough that I should be able to trim it. And I don't want to soak it because it'll be too soft. And then we're going to trim it down. And I am intentionally making this larger so I can take some away. So I'm going to cut way back here. So this site should be larger than where I need to be, but this is the part that I'm going to place into this site. So I'm gonna open that up. And we can see our sutures there. So I'm gonna place that there. And I'm gonna use my tools. And the goal is to press that into that site. So I am just gonna sit here and wait while blood softens this and fills it up. So I'm just gonna wait. See how it expanded a little, but it's definitely filling that entire space between those two roots. And then when I close that, it should be good. It's placed into the site. And now I'm gonna close this. So we have a tight gingival collar. I haven't finished knotting it, though I do wanna show you how I'm gonna trim the edge. Okay, that should be 4 rows. 2 millimeter, 3 millimeter, 2 3 mil tags. And then I am going to grab my instrument again, and I am going to, make sure that this little bit leaked out.
It's nice and firm in that whole area.
Now, I haven't finished closing, but you can see how it has a tight gingival collar to that site.
hopefully that made sense how it's used. So in summary, we want to clean our site well. If it's dirty, you're going to have failure. I've said this, I think, 3 times because it's so important. The difference between closed and open root planing and making sure we clean it well. And greater pocket depths require flaps, so you may have to open it. You want to open it if you have vertical bone loss. You want to consider this for as guided tissue regeneration. We want to make sure gingiva is there, not mucosa as a tooth collar. And so that's where a split flap comes in. And that's what I want to explain to you because this is Dr. Alex Ryder's technique. So I had one site I told you that failed. And what I had happened is that there wasn't a cut there. I closed across it and it naturally kind of went like this. And so there was not a tight gingival collar here where I have this blue blob. And so I thought I had done it right, but it wasn't a tight gingival collar and that side had failed. And so it was a case that I probably should have used a split flap. And a split flap is where we make sure we want to have gingiva come around. So here's the gingiva, it's split here. And usually this is cruddy tissue that need to be trimmed. So let's show you. So essentially this gingiva here is now going to be here. And this gingiva here is now going to be here. And then you're going to release your mucosa of this area and bring the mucosa here because you can have mucosa in an edentulous area. So I don't want to have a gingival collar problem. So I want to make sure I have gingiva around any remaining teeth. And that's how I decide how to close and how to make my flaps is whatever gives me the best way to have gingiva around a tooth. So this gingiva is this length and I want it to go around the tooth. So I want it to go here. Does that make sense where that one would go? And then this gingiva that's here is going there. If it was longer, it would go like this, but it's not. And then that leaves us with only mucosa. And so this mucosa will be released and then be put here in this edentulous area because we already saw that this tooth is really diseased. This one had to come out. And before I got this ready to close, but I didn't close it because what I ended up doing is placing a ReGum square right here to fix this little bit of vertical bone loss. Does that make sense? Let's look at another picture when it's done. So it's open it up, taking out this diseased tooth, making sure it's clean, root planing against this site here, get the flaps ready to close with fresh edges, and then I'm going to place ReGum, dip it in saline. This one doesn't need trimming. I can place the whole square in there, place the square in, and close. And so here is it closed. Let's get these lines off. Okay. So that one that was there is now here. And this is the knot that tied it. And the one that was over here is now here. And this is the knot that tied that one. And then the mucosa I released, and I just used a cruciate stitch to bring that together over here. And it looks gross with all the lines on it. And this is a small dog. So hopefully that makes sense how that looks. I mean, very small. We'd have the salivary tongue papilla things. So there are lots of different graft types. There's lots of barrier choices. All products have a place, but ReGum really makes a difference in how we can treat these areas. I hope you enjoyed this. If there's any questions, there'll be some information found at tooth.vet/ReGumVet. And then I would encourage you to reach out to BioChange as well.